thing was. Because that is your gear. When you get out on the lane and you say, oh, I don't have that because somebody didn't pack it for me, I'm not going to feel sorry for you. Okay? Somebody packs your bag, go through and look where it's at. Just the way you would go look through a med cart in your clinic to make sure that you know where everything is before you treat a patient. Good to go? The exact same. That is your gear. That is your patient. That is your life to save. As soon as I touch that patient, your time will start. Okay? Again, like I said, we're not doing anything strenuous. Those patients will be lying on the ground. Everything will be provided for you. You're not going to drag them. You're just going to go and treat. The only movement of the patients you're going to do is when we roll. All right? Are we all ready? Okay. Come to the patient. Massive hemorrhage. We automatically know you have a blown off leg. Correct?
You can report this if you think
Tourniquet. We drag our patient. Now we're here, right? We're here. We move the patient. Checking for bleeding. Carotid check. Look, listen, feel. Don't have any respirations. What do I got to do now?
Pretty good.
All right. Look, listen, feel. Looking for lobs, lacerations, obstructions, broken teeth, blood, swelling. I don't see anything. Patient's still not breathing. I readjust. Looking for lacerations, obstructions, broken teeth, swelling. Doesn't work. Now I have my first intervention. My APA. I will lube it up, bevel towards the septum. I meet resistance. I'm going to pull back. Doesn't work. Contraindication would be maxillofacial trauma, head trauma, deviated septum. Doesn't work. Doesn't work. It's fine. I'm going to find, now I have to go to my cric, correct? Find my cricocartilage, thyroid cartilage. In between are my cricothyroid membrane, correct? Brace my hand, find the site, making a 1-inch vertical incision, a horizontal puncture through the membrane. I secure my sharp, I hold my place, I find my ET tube, find my syringe, 10 cc's. You will have a stylet. I am inserting the ET tube down towards the chest, feeling for tracheal rings, looking for tinting. I don't want to see tinting. It's all the way down. I see misting in the tube. I feel air, respirations in the chest. Inflate my cuff. I have respirations. Next, combat second base, correct? I'm exposing the chest. I am inspecting. Automatically, I see an entry wound, correct? I'll take, seal. I'm going to place it, my occlusive dressing, on exhalation, correct? All right, now it's time to do my tiger claw. Get my tiger claw. I go all the way up to the traps, correct? In. I find another one. I wait for my patient to exhale and I place it down. Okay? All the way, belly to the belt line, correct? Now it's time for me to roll my patient, correct? I roll my patient. Good tiger claw. I find an exit wound. I'm going to place it. And I'm going to tape all 4 sides, correct? It's not the best tape in the world, but we use what we gotta use, right? Okay, all 4 sides. Excellent. Continue my tiger claw to the belt line as I roll back over. I follow my patient. We're good to go. Right? Okay. Now we're checking for step-offs. Decap BTLS down the spine. Credit card swipe. Roll my patient. Checking for bleeding. Correct? Reassessing my interventions. Looking down the chest. I notice that the right side is not rising and falling anymore, correct? I suspect a tension pneumothorax. To treat a tension pneumothorax, I use a needle decompression, the second or midclavicular line, second intercostal space, using my 3 1/4 inch 14 gauge catheter over the needle. I am going to go bevel down over the 3rd rib at a 90-degree angle in the second intercostal space, down, all the way down, feeling a pop as I go through the pleural space, listening for a whoosh of air, respirations return, secure with tape. I'm going to constantly monitor my patient's breathing to make sure he's okay. Respirations is done. Now I need to talk to General Mattis, so we need to pray. I'm going to pray. Checking for sternal stability, rib cage stability, getting to the abdomen, checking for turds, because this is where turds are made. Tenderness, rigidity, distension, swelling, correct? I get down here, checking the hips. As I do, I find a venous bleed, correct? That needs to treat. I'm going to treat with combat gauze. I'm going to soak it up, dry out the bowl, find the source of bleeding. At that time, make a ball. Now I'm going to pack this wound as much as I can. tighter I can pack this wound, the better. Pack it until I can't pack it anymore. Then what am I going to do with this excess?
Cut it.
No,
Well-
you're going to use that excess, right? I'm going to place my knee here on the inside, correct? Okay. Now what am I doing? Direct pressure for 3 minutes, correct? Excellent. So 3 minutes has been obtained. All right. That time. Now I have to bandage it, correct? I'm going to continue. Decap BTLS, down the legs. What does decap BTLS? Deformities, contusions, abrasions, punctures, tenderness. What? Lacerations, swelling, correct. I find a shrapnel injury, correct? How am I going to treat that?
Bulky dressing.
Yeah, bulky dressing. I'm going to choose to use the donut method. Okay. Because we treat these injuries, these non-life-threatening injuries, right, as we go, correct? So we don't forget any injuries. We don't want to skip over, like, oh yeah, I'll get that one in a minute. No, we get it right now. Super little awesome knot, right? Who taught us that? Which instructor taught y'all that?
AO.
AO, right? Alright, good. Alright, so now I move down to this leg. Alright. Oh shit. Okay, what do I need to do? First of all, we already know, yeah, we're going to splint it. That's how we're going to treat it. But we need to check PMS, correct? Alright. Alright, so right there, we're saying, boom, he's got pulse. We're checking the dorsalis piece. He's got a pulse there. Great. We'll want to loosely wrap this. Okay. Really want to start from the bottom and go up. Why do we want to start from the bottom and go up? Huh?
If it comes undone, it doesn't come off, it'll just go up.
Alright. You start from the bottom and go up
Straight.
because it pushes the swelling up. Okay? If you start from the top and go wrap down, it pushes that swelling down. It can't release up. Okay? So we said, hey, we're going to splint in this position. splint. Okay. Excellent. Now we're to the arms. Decap BTLS down the arms. Close the fist. Decap BTLS down the arms. Close the fist. We're good. Checking bilateral radial pulses. Feel weak and thready, right? Lost a lot of blood. Saying that this patient is going into shock, correct? If they were bounding, okay, then maybe not going into shock. Absent, our next check is a carotid. We want to check and see if that patient is alive. But we have weak and thready. Absent. Well, we get 30. We know that he's going into shock. We treat shock with fluid resuscitation. Correct? All right. Fluid resuscitation. We'll try to get my IV side. Boom. From a vein, I anchor in. Missed. Damn it. What am I going to do now? Huh? I would try the other side. Alright. Miraculously, he spontaneously just lost his arm. Right? What is my next option? IO, correct? Alright. We're teaching the fast one. Apparently, the fast ones are broken. So, but we're going to find our sternal notch. We're going to place our dome patch. Okay? By peeling the first sticker, placing it down, peeling the second sticker, making sure it's there. Now we're there. Alright? There will be a circle target. Alright? Above the manubrium. That is what you're going into. You're going to take your inducer. You're going to stick it straight on that target hole. And you're going to place down at 90 degrees with 60 pounds of pressure until you feel a pop. And you're all the way down. You're going to pull back out at 90 degrees. Just going to leave the infusion tube in. You're going to take and connect the infusion tube. You're going to take 10 cc's of normal saline. You're going to flush 5 cc's to flush out the bone plug. Then you're going to aspirate, looking for a marrow color in there, right? The pinkish brown, whatever, right? Then you're going to flush all that 10 cc's back in there. Make sure that bone plug's out of the way. You're going to connect your line. I choose that I'm going to run TXA first. How do we give TXA? 1 gram with
10 minutes. With
100
mLs.
of what?
Normal
Saline.
saline, about 10 minutes.
Okay, over 10 minutes, because we don't want pressure to go down, right? If the pressure goes down, what do? We slow the infusion, right? Okay, so we slow the infusion, 10 minutes go by. What are we going to run next? Hextend, right? We want to get some volume up. What's Hextend? Blood volumizer. What is the dosage? 500 milliliters. Bolus. exactly. Can we run it through the same line?
Yeah, I gotta flush it first.
Gotta flush it first, all right? Or a new line. So we flush it, boom, we're gonna go back on our way. Let's check bilateral radial pulses. Bilateral radial pulses have returned. Now I'm gonna check the head. My next. Head for decap detail less. Get the eyes. Use my pen light, looking for perla, pupils equal, round, reacted to light. Accommodation. If they are awake, right, to where you can say, focus on my finger, focus on this finger, focus on this finger, focus on this finger. Accommodation is bilateral pupil accommodation, focusing on near and far. EOMI is follow my finger, okay? Looking for nystagmus, that is bouncing, okay? All right, we're good. We're looking at our nose, ears, mouth, eyes for fluid, okay? If we have fluid coming out of them, we're going to use the halo test to check for CSF fluid. Halo test is dipping that gauze in the fluid, and then we're going to set it down, okay? And we're going to come back and look at it later. It's not an instantaneous test, but CSF fluid is antagonistic to blood, all right? Because we have a blood-brain barrier, correct? All right, so we got to let that shit sort out. As we do, we're going to look back in our mouth again. Maybe we missed something. Also looking for raccoon eyes, battle signs. All right, then we're good. Next is hypothermia, correct? It's the other part of the H. And it's good because the chopper is on its way. The chopper, correct? So we need to get this patient ready for transport. You have an option when you roll your patient the first time, when you're checking to get them on the stretcher at this time and treat for hypothermia. I don't care when you do it, as long as you do it. Okay? But this is the hypothermia phase. So this is what we're going to do. Once you get this patient on the stretcher, that is when your time ends. All right? And then you will talk to us about your 9 line, correct? All right.
So once it's on the litter, time stops.
That's correct. After going through everything, right? All right. So, roll my patient. We're here, correct? All right. So let's talk about antibiotics. Does this person have medications? Does this person have wounds that are open?
Yes.
Yeah. So he's gonna get what?
A gram, was, can he conscious?
Huh?
Is he conscious?
What is? He has open wounds. What does that indicate?
Antibiotics.
Antibiotics. So let's talk about antibiotics first. He's definitely gonna get antibiotics, right? Okay. So what antibiotic can I roll through him?
Moxifloxacin.
Moxifloxacin. We're gonna give this person a pill that he has a trach crack in.
A pill? No.
Oh, that's a pill.
No, no. So combat pill pack's out of the way. What can we give this patient? Ertapenem, cefotetin, ertapenem, 1 gram,
Ertapenem.
1 shot, 1 time, once a day. Cefotetin, 2 grams, 2 times a day. All right, every 12 hours. Those are IM or IV, right? Analgesics, if they do come awake. Are we going to give it to him? Probably not. He's out of it, okay? Let's say we do have a patient that we can give ketamine to. What is the dosage of ketamine?
800.
No,
It's 50.
that's fentanyl.
It's 50 for 30 minutes.
50 for every 30
IM.
minutes for IM.
And 20 for 20 minutes for IV.
For IV, right? Until what? Nystagmus has been met. Okay? That's what the cops are trying to get you at when they say follow the finger. That's how they tell you're drunk. Okay? That's how you tell homeboys high too. Okay? Alright? Just checking for nystagmus. Alright, so 20 for 20. Or
50 for
30. 50 for every 30, right? Alright? 800 micrograms if we're going to use oral fentanyl citrate, which is a little sucker. When you take the person's finger, they can choose to put it in their mouth. As they pass out, it comes out. Correct? What are some indications that we're not going to give this to? Dog tags, right? Or allergies. Unconscious. You know, those types.
Hypertension.
Huh?
Hypertension.
Hypertension. Okay? Respiratory distress. All things that we need to think about when we're giving medications. What's the last thing before we can get out of here? You gotta tell me your 9 line, right? So what's the 9 line? What's the 1?
Location.
Location.
Frequency.
Frequency.
Patient by priority.
Uh-huh.
Extra
Special
equipment.
Yep.
Alright. And then 5
Is number of patients by type.
Type.
by type. Okay? That bird is in the air. It's here. Boom. You're done. What time? How long was that?
26 minutes.
26 minutes.
I had you at 22:55 when you started talking about minutes.
Right. So 22:55. Thursday is gonna be easy fucking day. All right. Just don't fuck it up. All right. All right. Y'all good? Y'all ready to practice for yourselves?
No.
All right. So let's reset and then everybody, or let's pick a station and let's get after it. So
You can practice this at the house.
For each other. Could do it on stage.
Still recording.